young people can get cardiac arrest. Why is that happening?
All cardiac arrests are because of heart attacks. But all heart attacks don't end up with a cardiac arrest.
The robot operates on its own without any human control.
Absolutely not.
It's risk-free compared to open heart surgery.
No.
Any hospital with robot can perform a surgery.
Not true.
Hello and welcome to the News Minute. This is Real Talk. Joining me today is Dr. Mohammed Rehan Syed, who is a cardiothoracic and vascular surgeon who has 27 years of experience in this field. So thank you so much for talking to us. This show is powered by Apollo Hospitals. So my first question to you, we keep seeing videos on social media where people just collapse and die of cardiac arrest. Young people actually. Why is that happening?
Cardiac arrest is a very general term. So what they are having is an attack. All cardiac arrests are because of heart attacks. But all heart attacks don't end up with a cardiac arrest. So you can have a mild attack and things, you need not have an arrest. But if you have a really bad one, then it's called a cardiac arrest. So when the heart really stops beating, that's when it's called as a cardiac arrest. So this is more common. What we're seeing is in people who go to the gym and after 1 or 2 hours after returning from the gym is when this is happening. It doesn't happen when they are in the gym. It's after they finish with the workout, then when it happens. And this is because of something called as a plaque rupture. So just in a layman terms, you have a road. It's clean. You have trees on either side. The trees are a cholesterol. They're all at the side. The road's free to walk. No issues with it. Now rain came, storm came. One of these trees fell and fell across the road. What happened to the road? It's blocked 100%. This is exactly what happens. So this is plaque rupture. Cholesterol stays at the side, stuck to the side of your arteries. If we exercise or let's say stress, excessive stress, or just that your genetics are bad, lot of cholesterol and thing, or your calcium score as they call it is very high, then you are at a risk for these plaques to rupture. If they rupture and fall with 100% occlusion, then you will die, or you will have a cardiac arrest. But if they fall with just 30 or 40% block, then God's on your side. You can figure things out and get them fixed.
So what do we do to prevent?
I think you'll have to get back to a healthy lifestyle. But my advice would be to people who have a strong family history. Let's say I'm 45, or let's take the age down. I'm 35, but I have a very strong family history. I smoke. I have been irregular about my lifestyle till now. If I'm going to embark on this journey, personally, I would suggest, this is my personal idea, is that you should get a CT calcium score and figure out if you have significant high calcium score. If your calcium score is very high, then you want to start this whole process very slowly and gently and not rush into something like, a gym trainer putting you through 30 minutes of high intensity training. No. Take it easy. Start easy, slowly and get there because you are at a risk of plaque rupture. So I think that screening and then going forward would be a safe way to go forward.
Okay, that's the ideal way to deal with it.
Personally, that's what I train also. I'm an athlete. I train, but every time I'm going to train for something which is like serious stuff, like, some championship or something, I get my CT calcium score done and then only I get in because I have a family history and I can always have a plaque rupture.
Okay, but this is, the age group is also very shocking, right? Like a lot of people keep messaging, tweeting, saying he was just 22.
But Indians, we are prone to much younger age. It used to be 60 first, then it became 50, 40, now it's come down to 30. I think that's because of our lifestyles and things. COVID, there's a lot of talk that COVID contributed to it. Maybe not. We are not able to put a finger on it. We are not able to prove it. But yes, we are seeing like really bad heart attacks now post-COVID than we did pre-COVID. That's true.
Coming to your domain expertise of robotic surgeries, how aware are people about robotic surgeries? Maybe you can compare it with the rest of the world, like the Indian situation.
I think we're still, in India, the awareness for cardiac surgery and robotic cardiac surgery is not very great. I have practiced for 19 years in Bangalore, and there are 5 centers or 6 centers in Bangalore doing robotic cardiac surgery, whereas we have only 1 center in Chennai, Apollo Chennai, doing robotic cardiac surgery. So you can see the difference of awareness just city to city. We're right here. From going from conventional surgery to robotics.
Okay, what is the difference in doing a cardiac robotic surgery and a traditional surgery? Like,
So in a traditional surgery, you split the chest bone open. That's a fracture that has to be put together and it will heal like any other fracture. And that can be very debilitating to the patient, meaning they will take months and months to recover from it. So that's a problem. The advantage of robotics or endoscopic surgeries is we don't cut the bone at all. You go between the bone spaces and so there is no fracture to heal. So it's like you falling off a bike, you fell on some glass piece, you got a deep cut, you get stitched. That's about all the pain you'll have because you don't do anything other than that. You're not cutting any bone. So the recovery is much faster.
minimal.
Yeah.
Having said that, what type of heart conditions can be treated with this robotic surgery?
I think now at Apollo, I would say for us, it's pretty much everything we're able to do. So we do the bypass surgery, we do mitral valves or valve surgery. You need not say mitral, we do valve surgery, we do mitral as well as the aortic valves. We're able to do both of them. If you have a hole in the heart, I can close it with the help of a robot. And so slowly and steadily, we're covering the whole spectrum of cardiac surgery in it. There may be only say 10% of our work is we need to do open. 90% of the work can be done using a robot.
And the benefits?
You're out the door quickly. Like patients are walking the next day and they.
Is that become that easy?
Yeah, they're walking the next day.
Okay.
So they get up, they walk to the toilet, everything the next day.
And how safe is a robotic heart surgery, and what are the possible risks that are involved?
Safety wise, is the same as conventional surgery. The risk is around 1 to 2%, just like in conventional surgery. I think in robotic surgery, it is more important for the surgeon to understand what are his limitations. The surgeon has to be very, very honest about what he can do. Can he do one bypass only, two only, or three? What is his capability? That's all. If he is well trained, then you can do 5, 4, no problems. So you can do quadruple bypass through it. That is where the difference comes. So if the surgeon is not confident and decides to push the limit, then the operation becomes unsafe. And that applies to both. Even if someone learning on a conventional also, it is the same. Rules are the same, outcomes are the same, and the complications are the same. It's all within 1 to 2%. So there's no difference between the two. Except you, as a patient, you benefit from the fact that no bone is cut and the pain is less. And because I cut less, even bleeding is less.
So are patients, prepared for these kind of surgeries?
Yeah, they do come prepared. I have not had any problem. My patients come to me asking for this procedure because over the years I built a reputation for it. So I have people from across the country saying that we want this and we are coming to you for it. But otherwise, if you explain to a patient that these are the advantages, they will definitely be prepared for it. There is a cost difference to it. It is more expensive because the technology is more expensive. That is the only reason why they step back, not because of the operation otherwise. If you level the cost, everyone will opt for this.
Is it not, are there any measures that are put in place to make it affordable?
Not that it is, I don't think it is unaffordable. See, the cost of a robot is $2 million. And all these instruments, the way that company has structured it is they have finite uses, only 10 uses or 20 uses. And they're all fed into the robot. You can't hack it or you can't do anything. So that is where there is an additional cost to it.
Okay, can you give us some examples about how patients have taken it up? Like what was their initial reaction when you propose something like this, and after the surgery, what has been their reaction?
Yeah, so the main thing that there is that for them it's new technology. So the most common question I get asked is it the same as conventional surgery or are we trying something experimental? That's the first question. It's a fair question. If you don't know, you will ask me that question. So then I explain to them that no, this has been around for 30, 35 years. I'm only doing what is done. And even when I started off, one of the conditions for my patients was that I should be allowed to check angiograms to make sure that whatever bypass I'm doing for you is done well. So unless you gave me consent for that, the first 1,000 cases I did, I insisted on the patients giving me that consent, saying that it's a part of my learning curve. By God's grace, everything went well and results were good and stable and all that. Now in Chennai, after coming in, what I see is because it's new to them, this is the question. Is it the same as conventional? Can you do all the bypasses in that small cut? Are you able to see everything, do everything? Once they're convinced that everything is doable, then they'll again go back. Family will say, everyone has done this. Why do you want to try this? Then I think it's a matter of trust whether they trust me or not. But after the surgery, they're very happy that they took it because they see the difference. They're on their feet, they're walking, they're eating. It's not like surgeries happened. So that's a big difference for them.
The doctors enough, or even in colleges or even in medical.
Not in colleges. Medical colleges, I don't think they're there. I think this requires for the doctors to finish their post graduation and then go do a fellowship which specializes in robotic work. And that has to be outside of the country because the volume is there only outside of the country. I have a fellowship program now at Apollo where I have a person training who I am teaching how to do. And I run educational programs at least 4 times a year. But those are very short, 1 week program. This is a full 1 year course. It's a certification program. And so surgeons can come and join and work with me through the entire year. And I teach them, I let them operate, I hands-on teach them. So that helps build newer programs.
So this is being done by you in association with Apollo. Like it's a.
I am a part of Apollo, so it is a thing.
So there is also a lot of misinformation about robotic surgeries and particularly use of robot in heart surgeries. So I'll ask you the misinformation. Maybe you can answer those questions. The robot operates on its own without any human control.
Absolutely not. You handle the robot. The robot does nothing.
So what does it do? Like how do you handle it? Like
It's like me putting my hand into your chest and, like, say, setting everything up inside. So that hand that goes in is a robotic hand, but I am the one controlling that robotic hand. The robot doesn't know what to go on and do by itself. The other misconception, especially when it comes to bypass surgery, is the robot stitches on the heart. No, it doesn't. There are some centers doing total robotic, but the results are not very good and not being equivalent to when we stitch with our human hand. So what we do for bypass surgery now is we use the robot to set everything up so that we can make a small incision exactly at the location which will give us complete access, and then stitch with long instruments, stitch regularly like we have done conventional surgery. And that is why the results are equivalent.
another question that internet throws up is it's risk free compared to open heart surgery.
No, no. Every surgery has some element of risk. That 1 to 2% risk, in which we cover bleeding, infections, and everything, that remains for both. They're equivalent. I wouldn't say there's less risk in robotic compared to open heart. I think both have their place, and both the risks are equivalent.
These are not frequently asked questions. These are all frequently the misinformation that is frequently available on internet. So there's another one which says any hospital with robot can perform a surgery.
Not true. You're a reader. There is a book by a guy called Malcolm Gladwell called The Tipping Point. If you read that book, it'll tell you that everything in life, every single thing in life has a tipping point. So I think it's the Ninth Symphony of Tchaikovsky or Beethoven, one of them, which is a very, very complex symphony to play on the piano. But a pianist, for them to be able to memorize it, they need to have played that 10,000 times. Meaning, for them to get up from their sleep and come and do that, it requires 10,000 times. And that 10,000 number kind of runs for pretty much everything in life for us. And that is the tipping point. So if you want to be a good robotic center, and that's been proven for all surgical specialties, that the more volume you do, the better you become and the safer the center becomes. If you're doing just limited sporadic cases, then your risk profile is very high. So that is important. So robotic cardiac surgery, why Apollo has been able to lead the way is we do around 200 open heart surgeries a month. This is a center that's been doing this for so many years, 50,000 plus. So for them to move into this becomes an easier thing because the surrounding system is so geared to handling everything and to make sure that you go home fine. So that is why high volume centers do much better even with newer technologies than smaller centers. It's always a problem.
And how many surgeries you have conducted to robotic surgery?
If robotic, I must have crossed, say, 500 plus, but I do a lot of endoscopic and I have done close to, say, 5,000 endoscopic. So I have only taken the endoscope out. So the difference between endoscope and robot is the dexterity of the hand. In an endoscope, it's like a rigid pipe. It'll only move to a certain thing. It doesn't move 360. A robotic hand moves 360 clockwise, anti-clockwise, any plane. So that is the difference in dexterity. So for me, when the robot came, it was like, oh, this is a damn good toy, because suddenly my hands are moving 360. We're already doing endoscopic and we've been doing it successfully for many, many years. So to replace those endoscopic instruments with robotic instruments was the only difference that thing. So the learning curve was zero. So I think the way it has to go is the surgeon should be very good at conventional surgery. Then he has to become very good at minimal access or endoscopic assisted surgery. Then only go to robotic. If he jumps from conventional to robotic, if a problem happens in the robotic, he will have to open the chest up fully. That is, come back all the way to conventional, which is a major complication to deal with. So that's why the learning curve, the doctor has to be good and understand how the transition has to happen.
Has there been any cases where there were complications?
Yeah, see, we for us, patient safety is important. If you're doing a procedure and we find that the heart's not tolerating it, then we will either use the support of the heart lung machine and accomplish the procedure fully. But suppose that's not possible, and it is still there is no tolerance, and we are not getting enough space or room to be doing this comfortably, then you can convert to a thing. But that happens one in like 1,000, 10,000, like that. It's because here it's about planning and execution. So it means you planned wrong, so your execution went wrong. It's not nothing to do with the patient or anything. To start with itself, that patient would not have been a candidate. That's all.
In this case, if a patient has to undergo cardiac robotic surgery, what should be the age group?
No age group, it can go. I just did one last week on an 82-year-old lady. Small, tiny she is. She's going home today. She's fine.
And the recovery time is
6 days.
6 days. She's fine.
Fine. She's going. 82-year-old getting up, going home, saying, I want to go home in 5 days, 6 days. Will it happen with conventional surgery?
If a doctor comes and tells me that instead of me, it's a robot that is going to.
It's a not. Then you're worried.
I'll be thinking twice, right?
Correct. But it's not the robot doing it. It's the doctor who controls the robot. There is no surgery robotic that is done where the robot goes in and does its stuff and comes out. Even in the newer robot.
People have a different notion about it.
Yes.
I think that's the reason why it has to be simplified. It has to be told
Correct.
how it's done.
Yeah. The surgeon controls the robot. Yeah. So the robot is like an extension of laparoscopic surgery.
It's your hands.
Your hands.
Right, doctor. Thank you so much for joining us and explaining to our viewers in a very simple term about these surgeries, robotic surgery, and the importance of doing these kind of surgeries. Thank you.
Thank you so much.